Now I call upon Dr. Vrushali Ponde to deliver a talk on lumbar plexus block and Quadratus Lumborumblock.
Good afternoon. I think with the sake of time, since the quadratus lumborum anatomy has already been vividly explained in the morning, we shall skip that and we shall brood more on the lumbar plexus. So, on a certain morning, there was this young gentleman who went off to work and had some predicaments. And, he was trying to make his way. Somebody else came in, helped him across. So that is the purpose of these meetings. Well, so let's come to lumbar plexus block. Let's dwell a bit on the anatomy here. This is a story of one muscle. So this is the quadratus lumborum and this is the psoas. Now, if you really see the formation of it, of the lumbar plexus as such, we need to consider certain nerves, which are actually all these together. If we remove this muscle, we would see the nerves very clearly. So this is the femoral nerve, and these are all the other branches, such as lateral cutaneous, the ilioinguinal iliohypogastrics, and the obturator. So actually these two are neighbors to each other. The one which we have considered in the morning, we shall drop it right now. Well, the category of this block is, this is an advanced block. It needs to be considered only when exactly indicated. There are certain simpler and easier blocks before jumping on this, so one needs to be very discreet with its indications. The indications are usually the hip surgeries, the anterior thigh surgeries. And the reservations are, since this is a volume block, it's right inside the muscle, the reservation here is it can get absorbed, the local anesthetic can get absorbed, and the toxicity can be, in fact, a little more profound than the other techniques. So these are the cautions that we need to know about lumbar plexus. Coming to the position of the patient and the landmarks. Well, lateral position with the blocked side independent. An intercrystal line here joining the two iliac crests, and then the midline all along the spine. Another line through the posterior superior iliac spines. So we have two approaches here. One is the Winnie's and another is the Cheyne's. If it is Winnie's, then it is this very point that I'm pointing out right now here. Sometimes in practice we realize that slightly coming medially from this intersection helps to get the twitches. And if it is this approach, that is a line drawn from the posterior superior iliac spine to L5, then the midpoint of this helps us getting into the right track. In good old days, this is how it was done. We have indeed done these blocks with loss of resistance technique when the resistance and then the loss of it was given by quadratus lumborum itself, and then we assumed that we are in the psoas. And it was quite a discrete loss of resistance if you really see. Just watch this video, but we were not too sure about what exactly we were doing, and we had indeed a success rate that we wouldn't be boasting on. And it was a blind block, but this is what we did long time ago. But then the clicks and feels of the facial planes even still today help us. Well, in today's day and age, a lot of things can be combined, but lumbar plexus essentially remains a peripheral nerve stimulation block. This is how the back is cleaned and painted. Since the betadine need not be carried in, even just that portion can be cleaned. And what we really look into are the twitches of the quadratus. Here, during the trajectory, the light post is the transverse process. One needs to sneak underneath the transverse process and go ahead with the stimulation. We can start the nerve current at 1.5 or even 2, and maybe be happy with quadriceps contractions at around, say, 0.75 or 0.5. Remember, this is a volume block, so a lot of volume needs to be given for the block to really act. Yes, this can be given in any age group. Infants, typically 9 to 10 months old, are the right people to undergo the CDH, that is congenital hip dislocation repair. And when there are certain coagulation disorders such as Perthes disease, this does remain one of the good blocks to perform. We can do it continuously as well. So continuous blocks too help. This is the needle that we usually use, but this can be replaced by a cannula as well. This was just that our everyday practice has taught us. In this particular video, perhaps the trajectory might become even more clearer. I'm hitting the bone right now, which is the transverse process, sneaking underneath it, and I'm manipulating the needle to get the desired response. This is an adolescent patient. Through this, the catheter is inserted. A practical tip here is, if we could dilate the space by half of the local anesthetic dose, it helps in inserting the catheter, number one. Number two, by that time, the block starts acting because this takes its own time to act. Plexus blocks need time to act. If you are in the right plane and the right place, and the tissue dissection has happened well enough, the catheter passage is pretty smooth. This was the length at which I had got the twitches. So that gives us an approximate idea as to how much catheter should be left inside. Now it can be done with a stimulating catheter as well. I wouldn't go into the details of the assembly because you have just heard it in the prior lecture. So the stimulating catheter steps are as follows. Everything remains the same, just that you use the equipment that we just saw. This probably is going to show us every step and where we could go wrong with identifying the stimulation. This is an extremely superficial stimulation, needs to be ignored and go ahead with it. As we go deeper, these stimulations are going to vanish. And if we go get the stimulations on the posterior aspect, in fact, probably we are more towards the sacral plexus than the lumbar plexus. So we know which to ignore and which not to ignore. We need to all the time be attentive of the depth at which we are working. There needs to be a very fine-tuning of the current going on and the fine-tuning of the needle tip as well. This another response is one which I wouldn't like to consider because this is a deep response. It's in the deeper muscles of the back, such as the erector spinae. Or the psoas muscle itself can throw these contractions. But then we are not at the plexus as such. These are the posterior responses which we would like to ignore. We need to do fine tunings and fine adjustments till we get the response that we want to really see, which is the quadriceps contractions. And since the knee is flexed here, the patellar dance may not be that obvious. We could not have added the local anesthetic at this time point. Everything else remains the same. We could dilate the space with normal saline and the insertion of the catheter goes on, and then we stimulate it through the catheter again to get the desired response. But if you're doing this kind of a technique, we need to be there at least half an hour before the surgical colleagues, otherwise probably this is the result. Well, we could go give ultrasound as well, because ultrasound definitely is going to show us the trajectory, but is not going to show us the end point of injection, which usually it does, but in this particular case, perhaps not. So definitely ultrasound can tell us about the trajectory. If you really ponder a bit on this image, we can see the transverse processes. think it's, Manoj very fondly calls it a trishul, and in between, amidst the two, we will see the muscles here. The anterior side is the psoas. We could follow the needle trajectory this way, so it's more of an aided block. So we are too sure that we are not too lateral to hit the kidney, and we are not too medial to get into the epidural space. This could be done with an in-plane technique as well. But remember, again, the injection is always guided by the quadriceps contractions. So for a change, I'm going to depend on the endpoint which is given to us by PNS. This still is slightly medial response, and we would be adjusting the needle to get the response of exactly the quadriceps contractions. LA and dosages, we have been repeatedly hearing this sentence that it's a compartment block. So the dosages required are more. So there needs to be a fine tuning between the concentration and the volume. The volume here typically is at least 0.75 to 1 ml per kilogram, and hence the concentration needs to be reduced to 0.1 ropivacaine and equivalent with the bupivacaine. The local anesthetic infusion again can be ropivacaine. In infants, it can be 0.2 milligram per kilogram per hour, and in older kids, it could be 0.4 milligram per kilogram per hour. Well, the take-home message is here. Benefits of lumbar plexus block must always be weighed against the risk. This is a good block provided we understand it well. Thank you.